So coming to stage 5 ROP. Okay, this already we discussed. I'm just leaving what is meant by stage 5 A, B, and C. Aim here is to clear all peritoneal tissues up to the disc and open the peripheral trough all around to help settle the retina as much as possible. I'm not using settle the retina completely, as much as possible. And rightly what Parag again mentioned, you cannot induce PVD here. Most of the time it is other, so you will never be able to just induce the PVD like diabetes, what you do, and complete reattachment is not that common. Now, a lot of decisions you take when you operate these eyes, you need to understand pathanatomy. You need to look for a corneal status, look for iris, pupillary map, how is the pupil, whether dilates or not, whether iris is atrophic, iridocapsular adhesion. You have elongated ciliary processes, what you see here. Okay. When you plan surgery, you need to look at it. You go through that and then you lose the eye before you start the surgery. Configuration of detachment, and of course, if necessary, how the funnel is, pathanatomy again on ultrasonography if there is no view. Always you make a lot of decision, as again Parag said, under anesthesia. You speak to parents before surgery and tell them that maybe I'm going to examine baby under anesthesia, and then again I'm going to change my decision, my treatment plan may change. So look for again proximity of retina in relation with the lens, whether I should be able to do whether lens sparing, but most of the stage 5, eventually you sacrifice lens. Very rarely you will be able to save the lens. Look at a scleral transillumination. What I always say, then look for a sclerotomy site itself. That's the most important thing when you operate these eyes. And most of the time, retina is so anteriorly pulled, you do not have space to enter. Sometimes you do use transillumination. You depress these eyes like what you do scleral buckling. You localize your break. So here you do indirect ophthalmoscopy on the table. So depress or around just behind the lens or somewhere just behind the limbus. Look for where you get a space, something chink of space or some, when you press, something is opening up, find that space as your entry site inside the eye. So other issues are as usually poorly developed pars plana, lens is large, palpebral fissure is very small, also limited space, and you have a thin, extremely thin sclera with a low scleral rigidity. So again, stage 5B is okay, but stage 5 also have different scenarios. Yes, funnel is open, you see the disc. That's what stage 5. But retinal configuration still can vary. It can be just shallow detachment. You can retina is still anteriorly pulled. Maybe no or thin transilluminate and retrolentar membrane, or sometimes you can have very thick membrane and also pulling on a ciliary process. So these all various configuration, though is also called stage 5, but you have to make a sclerotomy that matters with it. Important is when not to operate. So you have leukocoria since birth. Remember, baby is not born with ROP. And if you have leukocoria as birth, that means you are dealing something else. So prognosis significantly change. Again, full-term infant with a stage 5-like picture, unlikely it is ROP. You look for incontinentia, or you have no disease, other options. Age more than 1 year is a relative contraindication. I would say if open funnel, I would still operate. But by the time the child reached 1 year, that means retina is detached such a long period of time. Generally, visual prognosis is really not that great. Corneal opacity, haze, again, they don't do generally well. And if you have very florid disease, probably you give some time, wait for a few weeks before taking for surgery because there's a high risk of intraoperative bleeding, and then you lose the eye. And something you see a lot of reduced axial length, a lot of echoes in a subretinal space, indicating subretinal hemorrhages, probably you would avoid operating these eyes. And with also closed floor configuration, the functional outcome is really that not great. So instruments, again, is a discretion of surgeon and also availability of the instrument. Most of us now start using a 25 gauge most commonly. Though 27 gauge can be used, but we still have limitation of instrument, the scissors and all those things. You don't have curved scissor there. And also 25/7 is still very flexible, particularly 25 gauge. When you dissect anteriorly, sometimes difficult to handle those areas. Short instrument obviously are available now, as you see here, 18 millimeter of cutter and 14 millimeter of light pipe. They are definitely useful, and you use a microscope illumination, most of the time coaxial illumination, that is useful in the eyes. So as I said already, talking about correct placement of sclerotomy is extremely crucial, because if you have inappropriate placement, you damage the crystalline lens, the first thing, anteriorly, and you try to save lens, and it will go push posteriorly, you will hit the retina, so you lose the eye there also. So Also, it's not conventionally the way you go with the three conventional sclerotomies. Here you look for where the space is, anticipate from which meridian, probably it will be easier for me to approach those fibrous tissue. My dissection become easier, so that you can sit on the temporal side, nasal side, or 12 o'clock area, depending on where you want to have your sclerotomies. Okay. So again, as I said, determine position, the same thing. So entry can be either corneal, limbal, or scleral. So this is something like you can use a 2-port or 3-port. Here just 2-port and use a visco intermittently to maintain the eyeball, IOP, as against you use a IAC maintainer. Again, that helps you to better intra IOP control and better hemostasis throughout the surgery. So because visco, when you inject, partly again, it keeps on coming and again, you have to stop surgery, keep on injecting again. Now, again, entry can be either transscleral. So again, you see you depress here as again I was talking about, look at the space here and decide, and depending on that, then you decide approximately somewhere as 0.5, 1 millimeter behind, if you have space behind the limbus, open the conjunctiva there. And obviously this is AC maintainer going into place, 20 gauge, because it is 20 gauge, so I use 20 gauge MVR, fix the AC maintainer. Other sclerotomy can be 23, now most of the time 25 gauge. If there is no space, what we do is either go through the clear cornea, but ensure that you are, while making a track, should be vertically down, because when you reach posteriorly, cornea can get distorted, as against, or you can go sometime, go through the limbus, through the iris root, and approach the retina. So every case is different. You decide, depending on where the space is, you plan your sclerotomies. Pupil, again, if nice, widely dilated, no synechia, probably is easier, the best way. But sometimes you have bound down pupil, you can use iris hooks, or if iris is atrophic, firmly other and posterior synechia, even sometimes anterior synechia, then you best way, sometimes this atrophic iris keeps on falling throughout. You just best to do is a sector iridotomy. Here you are not worried about cosmesis, you are not worried about photophobia, because vision is not going to be that significantly good at this stage that patient will complain of photophobia. What matters here is you get a good view for a surgery. Peripheral approach is very good if you do sector iridotomy, and some ambulatory vision. And most important, you want to avoid iatrogenic complication in these sides. Now, when you want to remove the lens, obviously entire lens has to be removed, including both anterior posterior capsule. And what I'm showing here is posterior capsule also being removed. Don't pull the posterior capsule. The zonules are very, very strong. What you need to do is hold the capsule with a forceps, and what I'm doing is cutting the zonules with the cutter and slowly rolling out the posterior capsule, simultaneously pushing it out, and at the end, just pull out through your corneotomy or sclerotomy, whatever you want to call it here. So ensure you do not directly just pull on the zonules. Otherwise, you give away. Pars plana is already taut, stretch, and if you tear there, you have lost the case. So coming to open funnel, that is 5A you talk about. So center part, sometime either you can cut with a cutter, or you use a blade, MVR or needle or scissor. And once you have that, extend that cut separation towards the periphery. And once you have reached the periphery, anterior you lift it beyond the retina and get a cleavage plane. This is what a scissor being used to reach to the periphery. Just grasp, it is always bimanual dissection under microscope illumination. You don't need any contact lens system here because axial length is overall very small. So, and simultaneously you tap the retina back with scissor, just blunt tip, and then once you reach periphery, and subsequently you move around. So when you come to now towards periphery, doing whether you start dissection center to periphery or periphery to center, again that again depends on where you get a cleavage plane. You have to be really opportunistic. You look carefully, focus that area, and you see a gap somewhere in a periphery. That's the best way to do it. Give a one's nick there, and once that you are act as a initial, like a point for initiating dissection, and then you go all along circumference. The iris obviously was cut here, so visibility is good. So you can keep on cutting, going along the periphery, along the ciliary processes. So that gives you actually excellent dissection plane, and also it helps you to open the peripheral trough as well. But sometimes you can't do that. So that situation is best way. Use a bend needle or MVR or scissor to slice across the membrane, or you can make a 4 cuts like 4 pi, and one edge of that peripheral cut here go along all around. Of course, you have to use scissor in both hand, bimanual going through and along the periphery, keep on cutting all along. Sometimes you can use a depression as well so that you minimize the risk of tug or traction on the extreme peripheral retina. And once you achieve that, periphery is dissected clean and you extend your dissection right in a central funnel. And this is what persistent highlight system going right up to most of the time you will be able to dissect it with, this is what is coming at last talk, with a more like a just blunt dissection. If necessary, small nick you can give. And what you are seeing, this is the end of surgery. You have a trough, open that side. This is, I think, not working. Trough on that around 2 o'clock area, other side on your screen, and center part is open. You do not aim to reattach retina on the table. You just leave it, this is the end of surgery, and hope that over a period of time, this retina settle down. Extreme periphery, sometimes to open the trough, you use a bimanual dissection. Again, if I am using it, depression, scleral depression outside, again is bimanual and trying to open this peripheral trough, because unless you open peripheral trough, the retina will not fall back, otherwise just holding it up, even though sometimes posterior pole does settle down. So you just give your own time, go small nick, slowly going on all around. Learn bimanual dissection most of the time. Learn to use your forceps and scissor in both the hands. That's very, very important when you're dealing with these eyes. So these are our first one of the publication. Yes, prognosis is not really good, but anatomical success, we could use 22% cases. That was the first publication. But as you see here, like a functional outcome, just what we look at is fixation of the light. Subsequently, we started using this MIBS, and when you look at it, 117 eyes, that is a publication. On stage 5, we could achieve 33% success rate. With this was a follow-up of approximately 6 months. And what we would do is like what we have a long-term public outcome, recent latest publication, what we have last, I would say, these are in between few cases. This is stage 5 going like this. Of course, this most of these eyes, you feel great while doing surgery, but look at this where retina is hardly viable, there is no vessel. But believe me, these all patients still have some ambulatory vision. And that's what at the end of the day, what you look for. And this is recent publication. We have long-term follow-up, 5 years or more. So what is important here is, though here 5 year and more, approximately 9 year on an average follow-up, we look at it. This is both group of over stage 4 and stage 5. The stage 5 group will be have 39% of eyes in this range, but initially success rate was almost 63%. And when you follow these eyes over a period of time, quite a few, it dropped down to almost 30%. So when you follow this patient for a long period of time, it's not like a surgery is over 6 weeks, 2 weeks, 2 months, things are well, but you just keep on following over a period of time, because traction you cannot relieve, babies are growing, eye size increases, and after some time, slowly retina sometimes can start getting pulled out. So it is a lifelong disease. You need lifelong follow-up, and not really, though initial success does not give you just continued for like it will remain as it is. We still have the best vision. We could got 660 in stage 5. I think that's a great achievement considering type of eyes we deal with. But yes, it is passion rather, I would say. So infants with a lower birth weight again and younger generation, younger gestational age, they generally have a poor outcome. With increasing age with each week, you have a better anatomical function, but obviously functional outcome drops down. Presence of anterior segment pathology usually associated with poor function. RD configuration and ultrasound usually generally no difference between anatomical outcome. And stage 5, as I said, higher rate of redetachment over a long-term follow-up. As you see, almost 22 to 35% can redetach over a point. So to conclude, stage 5 ROP surgery is one of the most challenging problem. Each case is unique and need an individualized approach and need to modify your surgical technique accordingly. Detailed pre-op examination and understanding of the pathoanatomy helps to plan your surgical steps. And though overall prognosis is poor, few patients do get good vision and it's still worth attempting. What is most important is parent counseling, rigorous rehabilitation, almost through few, at least till they become 8 or 9-year-old, and long-term follow-up is an integral part of management. I was thought of thinking of covering visual habitation a little bit, but I think next talk is exactly on that topic. So I'm just skipping that area. Once again, thank you very much for Arvind team having here, and thanks for patient listening. Thank you.